There we go. Okay. So before Dr. Fenton begins, I just want to remind everybody that even though he is a surgeon, he is not your surgeon, except for two people here, actually. He's not providing any direct medical advice today. He's here to share his own personal and professional experience with all of us. So please direct any medical questions to your own providers. All right, Dr. Fenton, I will go ahead and turn it over to you.
Okay, well, it's really a pleasure for me to be here today. I'm certainly glad, and I'm going to primarily focus on giant omphalocele and surgical options around it. I am from Salt Lake City, Utah originally, and I did some of my training here. I did my pediatric surgical training at the Children's Hospital of Philadelphia, and I've been here almost 10 years now. When I arrived, we did not have a formal fetal center, so some of you guys may have gone through fetal centers. Others might not have. When I got here, I started building it, and now we have a full service fetal center called the Grant Scott Bonham Fetal Center. So I'm really going to kind of talk about my experience, not just from training, but over the last 10 years here as well. So this is a picture of a giant omphalocele. This is on the day of birth. You can see, I've tried to block most things out, but you can see the baby has a little nasal cannula on to help with oxygen and what we call an Anderson tube or an oral gastric tube. It's pretty transparent here, and you can see small bowel. There's some stomach and some liver here. So giant omphalocele, we would classify if the liver is out or if there's a fascial defect that can be measured greater than 5 centimeters. And I am going to show a lot of pictures, some from surgery too. Hopefully you're not too queasy about that, but and these are all pictures of patients that I have treated over the years. So this is just another view of that omphalocele. I like showing it just because you can see it's transparent. Usually that's how it is on the day of birth. And again, you can see small bowel, some large bowel and stomach, and the liver sticking out. This is the omphalocele a few days later. It starts to become much more opaque as time goes on. So it's very transparent up front, and then it's opaque. And when I first started doing these, I was always very, very worried about it from a fragility standpoint. It's actually pretty stable. I would say there are some kids that are born that I worry more about how fragile it is, but as I have gained more experience in this, the reality is it is pretty stable, and we oftentimes have parents very early learn how to take care of it versus in my early experience, we would take care of it until we felt like the kid was ready to go home. So let's just talk a little bit about prenatal management. Typically, it's diagnosed on a screening ultrasound. We've already heard that today. Just ultrasound either at a mall or other institute just to get pictures can oftentimes find it. Typically, there is referral to a high-risk OB or maternal fetal medicine. Here in Salt Lake City, that consultation is referred to our multidisciplinary fetal center, where moms undergo verification of the diagnosis through ultrasound, are seen by one of our MFMs, pediatric surgery, neonatology, social work, and then as needed, other additional pediatric subspecialists, which I'll talk about here shortly, such as a genetic counselor or pediatric genetics and or cardiology. Sometimes they need to be involved. Here, we do not routinely perform fetal MRI. We don't feel like it helps us in the long run with management prenatally or afterwards. I don't say we never do it. We just don't do it routinely. We have had some moms that have required a prenatal fetal MRI based on additional diagnoses or other concerns to help us kind of clarify that. So most moms are followed on a regular basis with continued ultrasound. We do the delivery planning, and we plan on an in-center delivery around term. So most of these kids are able to get to between 37 and 40 weeks. And we usually set that up with a known date where moms deliver here at our center so that they can have neonatal and pediatric support afterwards. So let's talk about some of the associated issues with omphalocele, especially giant omphalocele. A lot of times these kids are born with pulmonary hypoplasia. We don't totally understand why, but there is obviously some play between how big the abdomen is and how big the chest will be. And depending on how big the chest will be, will also determine how big the lungs are. And so oftentimes these kids will need some sort of oxygen support after delivery. Some may even require a ventilator depending on how severe the pulmonary hypoplasia is. Often there are associated congenital heart disease or defects. And in reality, the smaller the omphalocele, the higher the risk of a congenital heart defect. And so we even if it's a small omphalocele seen prenatally, most of our kids will undergo a fetal echocardiogram or a fetal heart ultrasound to assess for structural abnormalities. And then obviously we have to figure out what we're going to do with the wound or what we're going to do with the omphalocele, either closure and or some sort of covering to help it stay healthy until it can be closed. And then the other anomalies that we have seen, not very often, but when they occur, is something called pentology of Cantrell. It's usually not just an omphalocele, but there's obviously there's oftentimes a sternal defect, so the heart can actually be exposed. There's a diaphragmatic defect, so the diaphragm has a problem as well. And typically those patients also have a congenital heart defect. So a defect, not just of the heart sticking out, but a defect within the heart itself that we have to get our cardiac surgeons and cardiologists involved with. And oftentimes also have intrinsic problems of the heart. Now, luckily, I've been here, 10 years. I've been doing pediatric surgery for 12 and general surgery for about 20. And I can count on one hand how many pentology of Cantrell's I've seen, so it's not very common. And then cloacal exstrophy is a problem with the development of the bladder and the anus and the rectum. And it is oftentimes associated with an omphalocele as well. And again, it's not a very frequent disorder, but it is a disorder that when an omphalocele is seen, we have to deal with. So this is just an X-ray of a kid who was born with an omphalocele. It was actually a ruptured omphalocele. That's why you see the springy thing here. But the reason I show this X-ray is because the chest is very long and narrow. We have oftentimes, or it has been historically referred to as a dog chest, because the reality is if you were to take an X-ray of a dog, it's very similar. It's long and narrow, and it's just reflective of those underdeveloped lungs or pulmonary hypoplasia and the problems that can come about because of that. So we're really kind of going to talk about surgical options, and the three surgical options that I want to kind of key in on are primary closure, staged closure, or a Schuster is another name for it, and then oftentimes what is called paint and wait. You could also call it sclerotherapy for the omphalocele. So let's just talk about primary closure briefly. It's really done for mainly smaller defects, so usually not a giant omphalocele, but one that we feel like the fascia or the muscle can be fairly easily brought together. We're able to close it completely without compromising the child. And I'll get into that a little bit more as we go along. And then it's usually not emergent. That covering over the omphalocele, what we call the amnion, that protects the abdominal contents. It protects the child. So usually these these surgeries can be performed within 1 to 2 days after delivery, allowing for the baby to kind of stabilize after delivery. And if some additional studies need to be done, like again, a heart ultrasound or echocardiogram, those things can be done prior to going to surgery. So this is just, this looks like a pretty big omphalocele, but the reality is there was no liver involved in it. And it was really more of a big sack of fluid. The little bit of stomach is sticking out here. And when we pushed on it, or I pushed on it, I was able to easily push everything in with the child not even on the ventilator. And I could feel that the muscles actually weren't that far apart. So this baby went to the operating room, I think 1 to 2 days after, and it was closed. In this approach, the umbilical stalk remained. I mean, I've honestly kind of gone away from that. I feel like I can make a nicer belly button or a prettier belly button without the umbilical stalk. I think there's a lot of my colleagues that still use an umbilical stalk for it. And this is just a little drain to help with that space. To be honest, I've kind of gone away from drains as well. I feel like it's okay if there's a little bit of fluid that gets there. That's just surgical preference, and there's not really any literature to say what is the best approach to doing it. And this is that child a few months later. That belly button you can see still has a little bit of an accordion to it, but what I've noticed is as time goes on, oftentimes that accordion kind of smooths out. Now, I will tell all of my parents up front in prenatal counseling, this is not a normal belly button. It will never probably be a normal belly button, and it might not be in the normal place as the child grows. So you may have to anticipate some sort of revision, either for a hernia and or for the way the belly button looks as the child gets older. And oftentimes with the giant omphalocele, I actually have a plastic surgeon assist me. And they can make a really nice belly button. I have some pictures upcoming. And you know, if the belly button needs to be revised for a hernia or otherwise, I get them involved later on to help sort that out. So this is just another picture of a omphalocele. You can see this is a few days old because remember, it's not transparent. It's much more opaque. And in this case, the omphalocele was fixed, and a little drain came out where the belly button was made, and it turned out to be nice, quite nice. I don't have any delayed pictures of this one. So let's just talk a little bit about paint and weight, and then I'll get into the staged closure. I honestly, when I was training, I learned both paint and weight and staged the Schuster as well as primary closure. And there were a couple of different camps. Some surgeons felt strongly about closing it. Other surgeons feel strongly about waiting on it. I think I kind of leave in my toolbox all three, but I have kind of moved away, honestly, from the Schuster unless I feel like it's just going to take 1 or 2 operations and to close, and it's not going to severely compromise the kid. And I'll talk about that here in a little bit. Paint and weight used to typically be reserved for giant omphalocele and reserved for kids where you felt like we could not close it completely without compromising the child. Or the child was so sick up front that they couldn't undergo surgery because of a cardiac defect or because of severe pulmonary hypoplasia. And it used to be called the quote unquote salvage procedure. But in reality, for us and giant omphalocele, it's really become our primary approach. And I know just in conversing with a lot of the fetal centers across the country, at different conferences, that they feel the same, that most kids will undergo a paint and weight and then be fixed at a later date. And I'll talk about final closure here upcoming. So how do we paint and wait? Well, we use Silvadene cream. Silvadene has silver in it, and it's an antibiotic. It's actually used in burn treatment. So patients that have severe burns. The nice thing about Silvadene is it doesn't hurt. It has good penetration into the wound, so good antibiotic coverage, and it's pretty easy to use. And it doesn't really cause long-term issues like would be if you use iodine. The problem with iodine is it can really be absorbed and it can change the iodine levels, and that can be problematic for the thyroid. And then there's some other things out there that can cause pain or don't have as good of absorption or are more difficult to use. So when we do wound care, and again, when I first started doing this, I would have the nurses do the wound care. We would put on sterile gloves. The ma or the baby would be in the NICU for some time until we felt like the omphalocele was stable. We have really moved towards fast tracking a lot of the care of our kids. So if our kids are no other defects, no other associated anomalies, pretty mild pulmonary hypoplasia, let's say they're just on a little nasal cannula, we get the parents involved really quickly on doing the dressing changes. And as soon as we feel like, or as soon as our neonatologists feel like the kids are ready to go home, they can go home. And we've had some kids go home as early as a couple weeks after birth. And I tell the parents, you treat the omphalocele like you do the rest of their body. So when you're giving a bath, you wash it with mild soap and water, and after you dry it, then you put the Silvadene cream on the healing amnion. So skin starts to grow from the sides and comes up around it. You don't have to put it on where the skin is. You have to put it on the other areas. And then you place, we use adaptic non-adherent gauze on that area. And then you wrap it with Curlex. And I say wrap around on top and go around the back. It acts as a support because what I want this to look like is a Coke can. I want it to be in the shape of a Coke can. And then you place Coban wrap around it, and I don't want you to compress it. I want you to just keep it the same size. There's no reason to put pressure on it. It will fall in when it's ready to fall in. And so here's the supplies that we use. Again, Silvadene cream, Adaptic non-adherent gauze, Curlex, and then Coban wrap. And so this is how I want it to look. And this was done by one of our parents. I usually tell the parents when you come into clinic, and I've actually tried to wrap it for them, and they said, no, 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 that's not good enough. They take it off and they do it themselves, and it looks perfect. And I took a picture of this because, this is exactly how we want it to look. And you can see that it goes around the back and goes around, and it kind of just maintains it a Coke can. I don't want you to squeeze it. I don't want you to make it smaller. I just want you to maintain it the same size as it is. So this is just a picture of the wrap going around the back. And here this little one is having some tummy time. And you can see that the parents put this little pillow there to support the omphalocele so that he could spend some time on his stomach. Now, while the kids are in the NICU, I'm going to show these pictures first. So this is what it starts to look like. And this is at 3 weeks. So, and this is normal. What's happening is it's become just like a big eschar. It's just like if you were to scrape your arm falling and just take off that outer layer of skin, or if you were to get burned, the body puts stuff out there so that new tissue can be formed. And that's what that green stuff is. It's eschar. And what the little pink areas are little islands of granulation tissue, and then skin starts to form. And it undergoes all these weird things. Little bubbles pop up and little areas that change. But the key is on these areas here, you put the Silvadene cream and then wrap it. And we want all this to form so that skin can come all over it. And you can see here at 4 months, now it's just skin. And so what I say now at this time, once it's completely covered with skin, is use lotion. You don't need to use Silvadene cream anymore. Use lotion to keep it nice and moist. And then wrap it the same way. Kerlix and Coban. Keep that Coke can shape, and it depends on how long it'll take to fall in. In this case, it was 12 months. And this is literally a picture that the parents sent me where it all of a sudden just fell in. And so there's this redundant skin. And now what I usually say is use an ACE wrap or something just to kind of hold it in. You don't have to wrap it anymore, just around the belly, just to kind of hold it in. And in this child's case, it took us a little longer. It took us till about 18 months for us to finally go to the operating room to close it. So here's just another baby, clearly much younger, has already fallen in, completely epithelialized. And again, they were just wrapping around the belly with a little ACE wrap, not too tight, just enough to kind of keep it normal and flat, and letting the baby do what the baby wanted to do, basically, as they continue to develop. Now, we send most of our giant omphalocele home from the NICU with a turtle shell. We have our prosthetics people come and they measure and they make this, and it has a little Velcro strap that goes around the back. We usually want the baby to have it when they're really kind of being held by people that maybe aren't really aware of the omphalocele, or by siblings, or when they're in their car seat, etc. They don't have to wear it all the time, but we do send them out with this little turtle shell for protection. So let's talk about final closure of after the child's undergone paint and weight. Now, I say it could be anywhere between 6 to 24 plus months. Now, why is that? Well, one, we want it to fall in on its own. And once it's fallen in on its own, then we usually wait a few months to allow the baby to grow and get used to it. Now, in some cases, when it falls in, there must be some kinking or pushing on the stomach. And so some kids have difficulties maintaining their weight and eating. And so at that time, we let them eat as much as they can orally, but we might have to add a little tube feed to help to make sure that they're growing. Sometimes based on how much skin there is, because if I go back and I look at this skin right here, we can't use this skin to close it. We need normal skin on the sides. And so depending on how much skin there is, if there's not a lot, I may ask our plastic surgeons to put in 1 or 2 tissue expanders and slowly over time help make more normal skin in order for us to close it. And then I tell parents, when we do the closure, you should plan on about a 2 to 4 day hospitalization, just based on how complicated it is and how well the child does. So here's that skin that I'm showing right now, and that stuff is new skin, but it's not good. We can't use that to close. We need to use the normal skin on the sides to do that. And so in this case, you can see all the muscle closed. This child needed a G-tube, so we put a G-tube in at the same time and then closed the skin. And it was our plastic surgeons that closed the skin. This is her just a few months later. This is another patient where we needed, you could see all the skin in the middle is not good skin. And so our plastic surgeons put in tissue expanders, these little bumps here where they access it with a needle to expand it over time. We went in and closed the muscle. That's the closed muscle. And then they closed the child up. This is a different child. And again, this is all that redundant skin that we're going to have to take off. And they closed and made a very nice belly button. And I just saw her in clinic, and she's got the best belly button I have ever seen on an omphalocele kid. So I took a picture and sent it to the plastic surgeon and said, "Nice job. Let's keep doing this." So what are some issues? Well, prolonged wound care. As a parent, you're going to have to do that dressing change on a daily basis for several months until it falls in and we feel like the kid is ready to be repaired. And so it could be 6, it could be upwards of 24 plus months. I've had some kids who were really, really complicated, who had other issues that we had to wait until they were more than 2 years old to close it. So sometimes, and you guys are going to be the ones that actually have to deal with that stigma. So explaining to others about an omphalocele when asked. And sometimes that can be hard. I've had a parent who told me that they're there with their little girl and their little girl's doing great, except has the turtle shell on, and they're waiting to check out at the grocery store line. And someone said, "What is that? Why does she have that?" And all these emotions came back to her as she was, sitting there. And that's the reality, is sometimes it's hard. People don't know about it. You might not have ever heard about it until you were given the diagnosis. And so sometimes you have to deal with that while you're helping. Now, from a developmental milestone standpoint, we let the kids move forward. I tried to look back through my photos. I've got like over 20,000 photos on my phone. But I have a videos that parents have sent me of their kids with omphaloceles, with the little turtle shell on, walking, crawling, riding a bike. I mean, what I say is let the kid be a kid. You're not going to stop them from being a kid, so let them be a kid, knowing that they have this, and helping them, in whatever way you need to for them to continue to develop properly. And so what I say with paint and weight is oftentimes you have to pay up front. You're doing the wound care, you're dealing with the stigma of it, you're helping them meet their milestones. And so up front, it's oftentimes a bunch of work and effort and payment, if you will. So let's kind of shift gears again and talk about a stage closure. And the reality is, when I trained, I learned stage closures. And again, I'm very selective now. I thought, that this was the way to go. And the mentality that has been in surgery for a long time is, this is a problem, we'll take care of it. And we can take care of it up front. And I think there's still a lot of surgery groups or surgeons out across the country. There's certainly not a consensus on how to treat these kids that still feel pretty strongly about closing it up front. Now, what is this? It's what we call, most do what we call amnioinversion, which we don't take off the omphalocele. We just slowly push the omphalocele into the belly until it's to the point where the muscle and the skin can be closed over it. So that takes a while to do, typically weeks. Several surgeries are required with general anesthesia to do so. It can lead to physiologic compromise or intra-abdominal hypertension, and you have to wait after each surgery for that to kind of resolve before you can do the next stage and the next stage. And so you do a surgery, and it's usually several days or weeks until you can do the following surgery based on how sick the child gets. It has been described as being done sutureless at the bedside, where they put some protective kind of what we call duoderm on either side of the omphalocele, and then they use a method to slowly close it and push it in until they can then go to the operating room and close the skin, or just leave it like that with a dressing. The problem with this is the same physiologic consequences happen as with surgery. We're pushing something that should be out of the abdomen into the abdomen. It affects the lungs, it affects the heart, it affects the kidneys, etc. And so you get intra-abdominal hypertension, and you have to wait until the patients overcome that to do the next stage. So this was made by Dr. Schuster. This is just a paper by Dr. Harrison and Adzik out of San Francisco. When we do it surgically, we actually go in and separate the skin from the amnion. We sew mesh into the underlying abdominal muscles, and then over time we go back to the operating room, squeeze on the mesh and tighten it a little bit more until we have everything in and can close the muscle and skin. So I'm just going to go through some pictures that represent this. You can see the omphalocele here. This is actually the mesh, or I'm sorry, this is actually the muscle. So we've separated the skin from the omphalocele, or the amnion. The amnion is still intact, but we've found the border between the skin and amnion, and then we go in and find the muscle, and we actually sew the mesh to the muscle here. Then we bring the skin up around the mesh, and these are the stitches that we use to tighten it. And every time we go in, we'll put a new layer of stitches and then cut off the excess mesh. And I'm just going to kind of go through these pictures here so you can see. This is a special dressing we put on to try and keep it clean because we're going to have to go back to the operating room multiple times. So we want this area to kind of maintain some sort of sterility or cleanliness because of the fact that we want to eventually close it. And so here we just can kind of see that we push it in until we get to the point where we can close it. This is a different one. So here's that border between the skin and the amnion that I'm talking about, even though the muscle is way down here. So the mesh is actually sewed way down here, and the amnion is left on. And you'll see again, here's that silo, if you will. And these are just subsequent pictures of us pushing it in over time. Now I'm going to show you I've kind of tried to close kind of keep the patient's face or their genitals out, but I'm going to show you a couple of things because I think in boys what we do is we really convert an omphalocele into a scrotocele. So most of these boys will have a huge scrotum because we've pushed everything in down low. And so typically they will require us to go back to the operating room later on at a later time, when they're older and more stable, and we fix those hernias. So here's the wound. You can see we've left a little bit of a drain there. And one of the things that we deal with oftentimes is wound issues. It starts with a little one. It just starts to open up. And oftentimes they open up enough that we have to do dressing changes, but eventually we get it to the point where they're closed. So I'm bringing up this child. I was not originally involved in this kid. It was one of my partners, but they asked me to get involved, and they had already done the first stage of the Schuster. And when I went to the operating room, it was clear to me that it was going to take us months and months and months to close this kid because of the amount that was out. And so I actually talked to the parents and said, I think we should do paint and wait. So that means take the mesh out, kind of reattach the skin close to where the amnion is, and then do dressing changes. Well, this is what the wound looked like several months later in clinic. And you can see it's, undergoing eschar, and we're starting to see some of that tissue form. Here is the kid, like a few years later, as soon as we converted her back to a paint and wait, she got off the ventilator. We were able to get her home within a few weeks. She followed me in clinic. Here's the wound. She'll probably need some work maybe with the belly button. We'll see. It depends on how she looks. I usually tell parents I wouldn't worry about it until it really becomes either there's a hernia issue or they're, kind of starting to go through puberty, and we know that they're getting into the shape that they're going to be in. And if we fix it, it's going to be a permanent fix. We might not have to do anything with this, but this little girl, she was not in the NICU for months and months and months, and you can see she looks, except for her belly, like a pretty normal kid. So the issues with the Schuster, in my mind, is it does lead to a much longer hospitalization, which is in the NICU. And most of these kids are in there for 2 to 6 months. If I close it, even if I close it within a couple weeks, the kids are on the ventilator for at least a couple months. And I have had some kids who've had such prolonged ventilation that they've had to have a tracheostomy. Now, some kids with a giant omphalocele, no matter what we do, because of the pulmonary hypoplasia and other associated issues, may end up in a tracheostomy. But that little girl probably would have had one, and you can see that she didn't need it. And it would have been strictly because we would have caused physiologic compromise by pushing everything in. And then when they're on a ventilator for so long, they oftentimes need long-term feeding tube supplementation or get oral aversion. And obviously, there can be some development delay in these kids because of prolonged NICU and prolonged hospitalization and ventilator, et cetera. So I usually say with a Schuster, you pay later. You pay in the long run because there's other issues because of the compromise that have happened with these kids. And I've, been in conferences where people have said, oh, well, we can do it now without undergoing general anesthesia and we can do it at the bedside. And my question is, how long were the kids in the hospital? And the average is like 72 days. So that's great. You can close the shoe, or you can close it without all these surgeries, but the problems remain. They're on a ventilator for a long time. They're on tube feeds for a long time. They're in the NICU for a long time. And in my mind, with the paint and wait, we can oftentimes get these kids home sooner, with parents. Yes, you have to do dressing changes, etc. But oftentimes, from a physiologic standpoint, they're pretty normal kids. Now, I said up front that some of them might still need tube feeds. You saw the one that needed a gastrostomy tube. We can't take all of that away, but most of the kids that I've seen where we've done a paint and wait approach, they come back, and in the long run are like normal kids otherwise, except for maybe a funny looking belly button. And so the Grant Scott Bonham Fetal Center is at Primary Children's Hospital. I give you this because please don't hesitate to contact us. I'm happy to talk to wherever you are, surgeons or physicians that may be treating your child. And, we certainly aren't saying if you're not in this region that you should come to us, because we know that that's far away. But we certainly want to be a resource and a help. This last slide is from one of our families. I mean, Russ and Aaron Bowers, they're the one of the co-founders, I think. Is that right, Parker? Would you say co-founders as far as Warriors is concerned?
Yeah, on the initial board, yep.
Yeah, and their little daughter Ella, and I texted Russ and he said I could share this photo, but their little daughter Ella is one of the first giant omphalocele that I treated here, and I have pictures from when she was newborn until this year. They send me pictures yearly, and I love to see it. This is her with one of our nurse practitioners, Tanya, who now works in the fetal center program with us, and Dr. Russell, who works on a lot of these kids along with me, both the fetal center and our pulmonary hypoplasia program clinic. Up at the Capitol, where the governor did a signing formally recognizing omphalocele and the challenges that are there for these patients and their parents and their families. I certainly am glad to the Clough family and the Bauer family for making Warriors. I used to refer, and I still refer all of my parents that come see me to, is it MOOBs, I think, isn't it?
Yeah, move.
Mothers of Omphalocele Babies, which I think is a really good resource. And I always say, please tell them you're from Utah, because people that are on there from Utah will find you and will give you information that is specific to our area. Because I think there's a lot of information out there that isn't necessarily great. And that's why I'm really grateful for Warriors. We refer to all of our moms to Warriors now. .org when they come into the fetal center, so that they can get this support, so they can get the information that they need, and they can hear it from moms and dads that have gone through this, not just from me. I always say, you'll hear my perspective, but my perspective will always be that of a caregiver and a physician. I want you to also hear the perspective of parents here who have gone through it. So I think we have about 12 minutes left. I'm more than happy. That's the presentation I have, and I'm more than happy to talk about anything we've discussed here, answer any questions.